So next is V5, acute scrotal pain. A 12-year-old boy presents to any with 3-hour history of severe right scrotal pain and 2 episodes of vomiting. His right hemiscrotum is swollen, red, warm, and very tender to touch. What is the diagnosis and how will you confirm it? All acute scrotal pain is testicular torsion until proven otherwise. A diagnosis of torsion is clinical. All cases should be booked for immediate scrotal exploration to confirm or exclude the diagnosis and to salvage the testicles. The role of diagnostic imaging Doppler is confined to the prepubertal boys in whom the testicular torsion has been excluded on clinical ground to look for other pathology. Irreversible ischemia starts 6 hours after the onset, with the salvage rates directly relating with the number of hours after the onset of pain. The differential diagnosis is torsion of testicular appendage. Dated of Morgagni, 45 to 50% present as an acute scrotum with this diagnosis. Other causes include the epidermolysis, idiopathic scrotal edema, hydrocele, testicular trauma, mumps, architis, nocturnal purpura, vasculitis. What is heredity of Morgagni? It is embryological remnant of the cranial end of the duct of Mullerian attached to the tunica vaginalis. It presents 90% of the males. What clinical features would be suggestive of testicular torsion? History: acute onset, severe pain, mainly testicular pain, may radiate to the groin, abdomen, or thigh. Acutely tender, on examination, acutely tender swollen testicle, high riding testicle in the scrotum with transverse that card being difficult to palpate, horizontal lie, and absent creeping reflex. The patient does not need to have all of these clinical features to have the torsion. How does torsion occur? It's bell-clapper deformity. How would you consent for scrotal exploration? So discuss the nature of the procedure, risks and benefits. The need for orchidectomy should be discussed in addition to the bilateral orchidopexy, including the presence of palpable sutures. Risks include swelling, bruising, hematoma, infection, atrophy of the testes. How would you perform the surgery? So say what you would do: paramedian transverse or midline incision. Divide the layer of tunica to expose the testes, untwist it and assist viability. Wrap it in the warm saline soaked swab for at least 5 minutes and reassess viability. If unsure, likely infected, you can test viability by inserting the tunica vaginalis of the testes and seeing if the underlying testes bleed. If viable, evert the tunica like a Jobli's procedure and perform 3-point fixation at both ends using a non-absorbable sutures. What are the long-term complications following torsion? So reduced fertility, infant reproduction engine, the damage the blood testis barrier which is resulting anti-sperm antibodies production. It is questionable if this is the cause of reduction in fertility. Testicular shrinkage up to 50% associated with prolonged duration of symptoms. Recurrent torsion occur in 4.5% post-orchidopexy and long-term follow-up. Thank you.